All right, we will go ahead and kick off. We've still got lots of folks who are joining in, but they will catch up. Welcome to this afternoon's discussion. My name is Jessica Todorovich. For those who don't know me, I'm the Chief of Staff here at the department, and I'm going to be facilitating today. So I'll lay out some housekeeping items, and then I'll be the one facilitating the questions. So I'll be reading your questions to Scott and Kathy, and they'll be answering them. So a couple of things that I want to start with. The first thing is, from a housekeeping perspective, please put your questions in the question box. So when you hover at the bottom, there's a chat and there's a question and answer. Please put your questions into the question and answer because that's an easier way for us to track it and to pull it afterwards. I anticipate there'll be some questions that really won't be answered today because they're not of the subject matter per se of today's discussion, but we'll be capturing those and making sure we're including them in Daily Dose, and will also help us continue to increase our frequently asked questions and making sure we get things addressed there. So again, as people are joining, please use the question and answer box at the bottom to ask your questions. I do have some preloaded questions that people have been sending in through the announcement of this webinar. And so I'll start with those questions as well. And then we'll be going through the ones that come up as the conversation happens. Couple of things that I wanted to make sure that I explained from the get-go. I am going to be monitoring questions, and I am not going to be bringing forward questions that aren't related specifically to the topic of this webinar. And that's because we've got Scott and Kathy here. They are very, very busy. We want to use their time to really get to the science piece, which is what this is about, which is the science of vaccines. So if you have questions about how vaccines work, what impacts might you feel if you were to get vaccinated? What is the data telling us about vaccines? What's going on with the FDA and approval of vaccines? Those types of questions. Kathy and Scott will be able to answer those. Questions about masking, about the requirement itself, any sort of policy or questions like that, we're not going to answer those today. Again, we'll update those in frequently asked questions, or myself and others will handle those questions offline. So I hope that is helpful. I'm going to turn it over and let Scott and Kathy introduce themselves and just share a little bit about why they're here today. And then we will start in on question and answer. You're free to use the chat if you want to communicate, but please don't use that for your questions because I'm not going to be able to grab them. Probably I'm going to be looking at the question and answer box. So let me start by turning it over to Dr. Lindquist. And Scott, would you be willing to just introduce yourself and kind of why you're here today? And then we'll ask Kathy to do the same.
Yeah, I'm Scott Lindquist. I've been with DOH for about 7 years. Previous to this, I ran the Kitsap County Health District. I was the administrator and health officer for 15 years. But my background is I'm an infectious disease physician. And one of my big areas of expertise is tuberculosis and respiratory viruses. So this is right up my alley. But I'm also at this point covering for Kathy Lofi, who was our health officer, as we've been looking for a new health officer. I'm the acting state health officer, what we call the chief science officer. And why I'm doing this is because I also have worked for one of our local tribes for about 20 years, and I still run a clinic. I still do clinical medicine. And a lot of vaccine requirements and questions are as a provider in the community. And I just wanted to make sure you had people available to you that could answer some of your questions. And Jessica asked me to do it.
Thank you so much, Scott. I'm so appreciative that you're here. And Kathy, would you introduce yourself, please?
Yes, absolutely. So my name is Kathy Bay, and I work in the Office of Immunizations. Actually, have been a nurse for 36 years. I have a doctorate in nursing practice and have worked in a variety of different clinical environments. I was in the Navy Nurse Corps for 20 years, and then have been again at the Department of Health for the last 5. And my clinical environment, as Scott said, his is infectious diseases. My clinical background is ER. I guess I think about that broad spectrum of the work that we do, but in the work that I do now in the Office of Immunizations, I really am the clinical lead for our team working on vaccine safety, immunizations, and work around that. I'm here because I believe in vaccinations and the impact that they have, and we can see the data on the impact that they have when we look at those that are unvaccinated. So I'm a strong advocate, but was also asked if I was willing to come, and happy to be here.
All right, so we'll get started with questions. What I can share with the folks who are on the call is that Scott and Kathy are two people that I really have found throughout the duration of this pandemic are people who are level-headed. They bring the science, they answer questions, but they also bring, they see us as people. They see us as people who might have legitimate concerns, questions, anxiety, and I just so appreciate that about both of them. And that's the last piece I'll say before we get started is I recognize for many of us, this can be a time of stress, and it never feels good to be told what to do. And there's also genuine concern, right, that people have around this issue of requiring a vaccine. And so I just want to acknowledge that. We're not going to spend time on that today, the policy decision, but I do just want to acknowledge, I recognize for some of us, this is a time of stress and trauma. And, so today what we want to focus on is those questions that might help people to understand. I am so sorry. There's something going on outside. You can hear all my dogs going crazy. To just focus on the science, the medicine, what we understand and what we know about these vaccines. But I think, we also have to acknowledge just that everyone comes at this from a different spot. And I've always appreciated that Scott and Kathy get that, and they're wonderful. Okay, we are going to start with some questions. I'm going to start with my list that I had previous, and then we'll go to the question box. These are in no particular order. I didn't know how to put them in an order, so we're going to bounce around all different subjects, but hopefully, because this will be recorded, people can find the right subject that they really want to talk about or hear about when they watch this back. So the first question we got was, why are people still dying if they have been vaccinated? I don't know who wants to. I'm just going to hand the question off, and you guys can kind of tag team who answers what.
Yeah, and I think, Kathy and I, we know each other well enough. We can just jump in on each other's comments. So, so here's part of the issue. We're looking at both who gets cases of COVID, who gets hospitalized with COVID, and who dies from COVID. And there is clearly no question. There is a big difference between those who are vaccinated and those who are not. Over 90% of cases, hospitalizations, and deaths are all in people that were unvaccinated. And that's really unfortunate. But that doesn't mean that just because you have been vaccinated that you won't get a case, get infected, that you won't get hospitalized or you won't die. When we look at our data, in those who were what we call breakthrough cases, so you were vaccinated, but you determined to have COVID, what we find is that while there were small number of deaths in that group, the majority of those people that died had pretty serious underlying conditions. So COVID may have been what tipped them over the edge, but the majority of those folks had a lot of underlying conditions and were older and had serious heart and lung conditions. But still in our mind and in the data, the majority of deaths, cases, and hospitalizations are definitely occurring in those who were not vaccinated. Kathy, anything you want to add to that?
Yeah, the only thing I'd add is that it's absolutely true that no vaccines are 100% effective. But as Scott said, consistently we find that when you look at outbreak information and you look at what's happening, those that are at highest risk are those that are not vaccinated. So the vaccine does have an impact on reducing the spread of the disease, so continued mutations of the virus, but also in impacting those who get vaccinated to reduce hospitalization, disease, and death for sure.
Thank you so much. In follow-up to that, I had a staff person ask, is it important or do you recommend that people get tested for antibodies after they've been fully vaccinated to see how resistant they are. Is that something that people should be doing?
Yeah, so I'll take this one. As an ID doc, the one principle I've learned consistently over time is that antibodies are not a marker for immunity. They're kind of a proxy. So that, for example, there's people that say they get a disease like COVID, and then they get their antibodies checked and they don't have any antibody. But yet they're challenged again with the COVID and they don't get it. So antibodies are nothing but a proxy to say, did you have a response or not? It does not mean you're immune or you're not immune. So with that in mind, I've always entered this, and sorry, my dogs are going to bark now. The package is here. But the reality is, no, you do not need to check antibodies after either a vaccination or an actual COVID infection that's been confirmed, because you're not going to do anything with that answer any differently. Kathy, anything you want to add to that?
Nope, that sounds great.
Great. And that actually leads to another set of questions that we got about people who have had COVID. So if I'm a person, let's just use me for an example. Let's say that I had gotten COVID at some point. Am I already, do I already have a natural immunity because I already had it? That do I even need to get vaccinated at this point? And if I'll just leave that question. Let's start with that question. So I've already had COVID. I know I had it. I got tested. It was positive. Do I need to get vaccinated?
I thought I'll start this one and then I'm going to hand off to Scott to finish the answer. But there's a lot of data. There's actually a recent article that got published in the MMWR about the fact that, again, even though you have some what we would call natural immunities after you've had the disease, those may not sustain for as long of a period of time as vaccination. And there's been several studies that have shown that individuals who are vaccinated, even after they have had the disease, have much longer lasting immunities and don't develop disease again when they are exposed. It's not necessarily that it depends on the severity of the disease that you have initially. And then again, the types of immunity that you create, which is a little bit more into Scott's work than mine. But it can make a difference. And the recommendation really is that those individuals, even if they've had natural disease and have natural immunity, should still get the vaccination series. So Scott, I'm sure you have more to add to that one.
No, I think you covered it well. I think you're absolutely right. Remember, everyone, this is a brand new infection. This is something we don't have all the experience and knowledge about. And a reminder, the first case in the United States was diagnosed by us at DOH. We were the first to have to figure out how long do you have to be isolated or quarantined. And so it's every day that we're getting more and more data, but I'm definitely on board with Kathy. The studies are showing, even though you had natural infection, once you have resolved your symptoms and you get vaccinated, you actually are shown to have more protection than just a natural infection alone. And that's kind of counterintuitive because, like things with chickenpox and other diseases, we know that natural infection tends to be as good, if not better, than immunization, but not in this case. It hasn't been found to be the case with COVID.
Thanks. And then the second part of that question for one of our staff members was somebody who's experiencing kind of what we call long haulers. So they had COVID. They have now the post-COVID syndrome. They have elevated inflammation levels and some things like that. The person's wondering, will the vaccine still be effective for them? Like, will it help them at all, or will the long-term COVID symptoms negate the effectiveness of the vaccine for them?
So I again, I'll start and then hand off to Scott. I think there's a lot of unknowns about the long hauler. We think that syndrome is very similar to at least what we're figuring. As said, this is a new disease for us, but We think that it's very similar to the idea of how a virus lies dormant in like the nerve root. So for somebody that had the chickenpox, for example, ends up with shingles later in their life, continues to evolve over a course of time. Most of the recommendations are still that the individual should be vaccinated and that it might help. But I would, from my perspective, still recommend that the individual speak with their personal provider, their medical provider, whoever they're seeing. That healthcare provider may have some additional recommendations, or there may be other things that should be done, because it depends on the severity. The range of symptoms can be pretty broad and can be pretty severe or more minor, and that would make a difference as well about how to move forward with that. Scott, other things to add?
Yeah. So this whole issue of what we call long haulers is, like Kathy said, very much unknown. I have really coached every local health jurisdiction to get people to sign up for the study that's being run by the CDC and the University of Washington. And as we gather more information, we can answer this with certainty in a year or so. But my experience with 2 long haulers were, once they were a couple weeks past their infection, they got a dose of vaccine, their symptoms of long haul went away. So these are anecdotal. The studies are still out, the verdict's out on this, but I would not hesitate to recommend COVID vaccine, the mRNA vaccines, for anyone who's experiencing long hauler syndrome. More to come as we get people enrolled in these studies. Again, Washington's leading the way on this, but we just don't have really good information right now.
Okay, thank you. I actually don't know if either of you are subject matter experts in this area. I'm going to ask the question, but feel free to just say you're not comfortable answering it. Some of the staff have said they've heard conflicting information about like case counts. Like they feel like their friends in the medical community are saying the data is actually higher than what we're reporting as an agency. And you know, without getting into details, I'm just curious from your perspective. You know, we continue to have these conversations about misinformation, and what is the information DOH is putting out there in terms of case infections, maybe breakthrough cases. Are you guys, any comments you'd make just on our data?
Yeah. So as a state epi, this is right up my alley. No question, we're underreporting our case counts because our case counts are based on national case definition. Okay, so that means they have to be with a PCR test or some other of the molecular diagnostic tests. But as you know, there's a huge boon in over-the-counter testing that people are doing at home. And they are not reporting those the same way as a lab will report them. So the surveillance system is never going to be able to capture all the tests that are done in the state of Washington, because people, I'm relatively comfortable that if it's done in a lab or in a doctor's office, there's requirements for reporting. But if they are not done in a lab or a doctor's office, then we are missing those because there's no mechanism for them to report to the system. And that problem is going to get worse as we get more and more home testing done. So on that standpoint, it's true. On the standpoint of breakthrough cases, yeah, I don't think we're capturing all the breakthrough cases either, because I'll give you an example. If we have an outbreak in a nursing home and we go into this nursing home and we test everyone, whether you got symptoms or not, we're consistently finding that 80% of all the positives had symptoms, but 20% did not. So that means we're missing 20% of the people who don't even know they're ill to even get tested for a breakthrough. So we are likely missing quite a few breakthrough cases that are asymptomatic. And that's not really, people are saying to me, well, you know, that 20%, it's a bad test. No, that's not true. It's with our gold standard test, the PCR, we're still finding about 20% of the people are asymptomatic. And as we have these large outbreaks, there was a big outbreak in Seattle in a gym. The people that got tested and they were vaccinated they all said the same thing. They're like, I had a runny nose. I didn't think I had COVID. I had been vaccinated. The only reason I got tested is because there was an outbreak here in the facility. So yeah, I think there's credence to the statement that our surveillance system is missing cases. Now, that's not unique to COVID. That is true of almost every other disease we have. Our surveillance system is not 100%. What data tends to be really good is hospitalizations and deaths. Those are such dramatic events that we tend to capture those pretty well.
So the only thing I'd add to that is where it's absolutely true that our data may not be, it's the most effective we can make it. We'll say that. It's not like there's an intentional plan to withhold information, but it's the best we can make it from that standpoint. But in association with vaccination, it continues to show us that even if there are breakthrough cases, that the fact that we're still seeing more cases that are requiring hospitalization and more cases that are dying that are unassociated with vaccination, that those individuals weren't vaccinated, it continues to show the positive impact of the vaccine and getting vaccinated. So I think pertinent to our discussion today, that's important to bring up. So
thanks. All right, we are going to tackle some of these questions online now. Are mRNA vaccines truly new types of vaccines, or have we used mRNA vaccines before?
So I would say we've used mRNA technology for other types of medical treatments. So we've used them for the purposes of, there's some cancer treatments and some interventional things. They've been available in some ways for between 10 and 20 years really in development. And so mRNA technology and the idea of using them for vaccines like this are much more and much newer to us. But again, the technology and the skill set and the work that we did that was a preliminary stuff, it really is one of those reasons that we were able to move forward in the US to be able to have the vaccines available as quickly as possible.
Yeah, so this is I think one of the myths and things everyone always talks about is that this is the experimental vaccine, or that's just simply not true. These vaccines, mRNA vaccines, have been around. There's been this technology has been used for things like CMV vaccine and rabies vaccine, Zika virus. There was actually an mRNA vaccine. So this technology, like Kathy is saying, has been around for quite a while. And these specific mRNA targets that are in these two vaccines, both the Pfizer and the Moderna, these were not experimental. These went through actual studies and certification through ACIP and the FDA. And quite frankly, they're all going to be FDA approved here within a year. But yeah, this is what I think this is nothing short of modern miracle of medicine to be able to have such a quick turnaround. If you would have told me when we diagnosed that first case of COVID, that was on January 19th, that within a year we'd have a vaccine in place, I would have said, you're nuts. There's no way we'll have one that'll be in place with 80 to 90% effectiveness. It's just mind-blowing. And the nice thing about this mRNA, the targets can be changed so quickly that as you know, we're seeing new variants like this Delta variant. The vaccine manufacturers are already targeting this Delta variant. They won't be long before they start marketing these for certain variants, because the turnaround time and the ability to change the targets is so wonderful. So, and by the way, I was really faced with this decision on a very personal level. As a physician, also working for the tribe and also as an ID doc, I had to decide, am I going to take these vaccines that have EUA? And I had to read all the FDA and all the studies look at the safety and the efficacy to decide for myself, is this something that I'm comfortable with? And I got to be very frank, I got my first doses in December of last year, and I didn't have a big question. The second biggest question point came for me and my family as I'm inviting the CDC to Washington to look up cases of myocarditis in kids is, do I recommend the vaccine to my college age athlete who's 18 years old when this myocarditis business was going on, and still is a concern. And so I had to wrestle with these issues also. And it's always, you make these decisions as a person or as a family member based on your perspectives. And I'm not hesitating to tell you, I had this discussion with my 18-year-old and said, look, you get COVID, you could get myocarditis, and the side effects from the disease itself are so much greater than the risk from the vaccine that we recommended it. And so thankfully, he did fine, did not have myocarditis, and I did fine with my vaccine. And you know, you guys, I have been in every prison in the state, and I have been in most of our long-term care facilities with outbreaks and our migrant farm camps where there's outbreaks, testing since the beginning of this. And yes, of course I wore PPE, but I was vaccinated and I never did develop COVID that I knew of. I was never symptomatic. Geez, I didn't even get flu or anything over the last year and a half. But anyways, I know this is a deeply personal decision. I'm just want to make sure you're understanding my perspective and Kathy's perspective on the science to help you make a decision. And I'm with Jessica. We had this discussion before. I don't want to be told by the governor or my employer what I must do. And I really understand the friction that has caused. But again, we're not here to debate that. We're here to give you our perspective on the science as people that deal with this. And just one last comment. I know it's more than the question asked, but one last comment. COVID is so bad that the side effects from COVID way outweigh any of the risks that I have seen or any of the side effects I've seen with the vaccine, any of the vaccines available here in the United States. COVID has been incredibly humbling, incredibly devastating, and we have death rates like we have never seen with anything like the flu. So with that, I'll turn it back to you, Kathy, unless you had anything you wanted to add.
No, I'll let Jessica go ahead, and then I might add my personal commitment and my personal philosophy on it when we're a little bit later.
Thank you. And I appreciate you both just being very vulnerable and sharing your own experiences, because that's, you know, part of it is just seeing each other as people and recognizing that, you know, we're all trying to make these decisions. The next question is, why is the monoclonal antibody therapy being slow to be used by providers? Are there any issues or side effects? Any myth busting we can help with when talking with families and friends?
Yeah, there's a couple of reasons the monoclonal antibody is not widely accepted. Is because, to be honest, you need to be able to put in an IV and run it over a time period. So it's not done in most clinicians' offices. It can be done, obviously, where you have the IV capability, but it requires monitoring and some technology and some technical expertise to place an IV and run it. The other real negative on this is some of the variants have shown no efficaciousness when treated with some of these monoclonal antibodies. So not all the monoclonal antibodies can be used. We have here at DOH have been incredibly aggressive talking about this, getting out this information, including, if you're ever interested, every Friday we run a local health jurisdiction call. I chair a call where we bring up topics. The topic for this Friday, one of them, is monoclonal antibodies, and really all the details of how to get it, where to get it, what to use, what doesn't work for which variants. And so this is something that we're doing pretty routinely, but it's just not receiving a lot of attention from clinicians and from patients. I think it's technically it's kind of difficult, and it's got limitations too. It can't be used in someone who's incredibly sick. It's really in those who are pre-hospitalized, so you can get it infused before your disease gets worse. But yeah, it is recommended by the Infectious Disease Society of America, though. There's no question about the science behind it. It's not as awe-inspiring as the vaccine efficacy numbers, but it's still quite effective and has very low side effect or risk.
Yeah, I do think there are some additional monoclonal antibodies that are becoming available or may now be available that can be done a little bit differently, maybe not through, they may be able to be injected as a subcutaneous or a IM injection. But there are still some requirements for monitoring, and it's not necessarily an easy one-shot process. The key is, as Scott said, the monoclonals are great if you have been exposed and you now have the disease, but you aren't sick enough to be hospitalized yet, then they're a good solution for someone. But for somebody to prevent, again, the vaccine, kind of stepping back into the idea, if we can prevent someone from developing the disease and not needing that next step, then to us, that's a better approach. So.
Thanks. Can one of you talk about shedding, what that potential is and what it really means for those that are vaccinated?
Yeah, I can start. So with any virus infection, especially a respiratory virus, it colonizes your upper respiratory tract and your lower respiratory tract. But you can imagine as you cough, you sneeze, you blow your nose, you spit, or in more extreme cases where it's very infectious, you exhale, you talk, you sing, you can shed virus. And most viruses are not respiratory spread viruses. They are spread through this. Touching your secretions, getting it on your hands, and then touching something. Here, I'm going to touch the camera. But what we've found with COVID, very unusual. There are less than 5 viruses I can count on my hand that are actually spread through the air. Respiratory COVID has been found to be one of those that does have respiratory spread. So the bottom line is, when we're infected, we shed viable viruses. Okay, and I say that very carefully because viruses are not living things. Contrary to what it may say on your Lysol can, that it kills 99% of all viruses, viruses are not living things. They are nothing but protein envelopes that get inside a human cell, use your human mechanics to make copies of the virus. So they remain viable. So when you shed a viable organism and it lands on a countertop, usually light or dryness, so UV radiation or bleach as it dries it out can make it not viable. But certain times you can shed viable virus, especially if it's through the air. So here's long explanation to get to this. What we knew about COVID from the beginning is absolutely not what we're dealing with today. The variant that we have now, we are shedding 40% more virus through our respiratory tracts than any other variant prior to this. So that this variant isn't more dangerous, not that it's more people or hospitalizes more people, it's just much, much, much more infectious. So it takes less time to become infected, you're shedding more virus. Even if you're vaccinated, you can shed this. Vaccination does not prevent shedding. It does not actually always prevent infection. What the efficacy studies of these vaccines really looked at was, do they prevent death? Do they prevent severe hospitalization and mortality? And the answer to that is, yeah, they do a great job. They do a great job even against the Delta variant. But for the shedding and the ability to get infected, that still remains a problem with this variant. And I know we're all talking about Delta variant now. I'm already warning people of the next one that's coming called the Lambda variant, which appears to be even more infectious than the Delta variant. So that's kind of where shedding fits in. That's where the vaccine fits in. So no matter what, vaccinated or not, you're seeing recommendations for wash your hands, wear a mask, and use respiratory etiquette. Cough into the crook of your arm. By the way, that's one of my pet peeves. You don't cough into your elbow because your elbow is back here. I don't think many of us can get our elbow to our mouth. But so using respiratory etiquette, and that's why you're seeing a lot of CDC looking at the science saying, well, vaccinated people can still shed viable virus. We should be wearing masks in public places. That's where a lot of this information is coming from. Okay.
All right, thank you so much. Okay, I'm kind of going through questions, trying to find ones that are unique. Lots of good questions. We do have somebody who has some pregnancy related questions, and I think I'm actually going to capture that name and we'll reach out specifically to that person. If we have
and
time,
I can
we'll
just
come
give you
back
the
to
quick.
it.
CDC is very clear. You're safe to get this whether you're thinking of becoming pregnant, you are pregnant, or you're breastfeeding, and it's on the CDC website. It's pretty clear. We didn't come out real strong with that message, Jessica, in the beginning because we just didn't have that experience, but we've had enough experience now to feel comfortable stating that.
And would you say all three options are viable in this scenario? Any of the shots or vaccines?
Yeah, they are. I think any of the vaccines you can get. I like the mRNA vaccines myself personally. J&J's had some struggles, especially with some clotting issues and things like that. But I don't know, Kathy, what are you thinking?
Yeah, I agree. All three of the vaccines are recommended. Now people have opportunities for choice because we have more availability of all of the vaccines in Washington. But not only does CDC recommend, but coming behind that CDC recommendation is the research looking at individuals who either were pregnant when they were vaccinated or got pregnant after, or they're breastfeeding. There's some really good data that's out there and continues to evolve about that. But ACOG, the American College of OBGYN providers, and the fetal medicine providers, all of the different leading agencies, these are not agencies really, these are medical groups and organizations that provide, there are experts when it comes to providing care for these individuals. They all really strongly recommend something of like 2.5, 2 1/3 to 2.5 more people who are pregnant who are at higher risk when they're pregnant, when they're unvaccinated. So they're really strongly recommending the vaccines for everyone who is pregnant, breastfeeding, or planning to become pregnant.
Okay, hold on just a second. I got to ask another question. So one of the questions is somebody's saying they're really, thank you. Somebody's saying they're really scared of possible side effects, like being physically damaged or harmed because of the vaccine, and that there's no really liability where somebody would have to make compensation for that, right? And their life would be changed. Can you talk a little bit about the risk around serious side effects of a vaccine and like anything you could provide around just context for somebody who's scared about that?
Yes, how about I'll get started and then Scott can add into. So there's a lot of vaccine safety work that happens. Obviously, the clinical trials that have already happened is to look at, are the vaccines safe? Those happen before the vaccines are ever available for us to use for general purposes. And I think of us as general purposes, right? We're not in that clinical trial. In addition to that, the ongoing kind of work that happens for vaccine safety, there's all kinds of look at, vaccine safety, and events can occur where someone got vaccinated and there's a temporal association, right? It's a time-based association. I got my vaccine and I stubbed my toe, or I had to hit a wall with my car by accident. Was it the vaccine, or was there a different reason for that to happen? So lots of ongoing work happens around looking at that after the event when that's reported. And there's lots of databases that are utilized for that, for the process. But there are programs that if someone actually has even a temporal association kind of looking through that process, they can request, going through, there is a vaccine program where they can request to have support, or support for the medical cost and other things. So I think that the assumption is, well, once the vaccine is out there, nobody's responsible for it, but there are ongoing processes that happen for monitoring, as well as try to help if there is a concern that occurs. So I think with that, I might let Scott kind of add to that when he has other things to say.
No, I think you said it well. I mean, personally, I've literally given thousands of these vaccines and I have not had a single person be harmed by it. So my personal experience is that as a clinician, I got to admit, the first dose of the vaccine I got the Moderna. I got sore arm, no big deal. I don't usually react to vaccines. My second dose, it kind of knocked me on my tail. I was pretty tired. I felt achy. And then the next morning it was completely gone. So that was my ultimate personal experience. But the perspective I would give you on this is the side effects and the outcomes for getting COVID itself are so much greater than any of the side effects or potential that I've seen with the vaccine. Literally had friends and folks that I know, patients that have died of COVID. So I come from a very different perspective. COVID is a much, much worse player in my experience as a clinician than the vaccine.
Yeah, just to add to that one more piece, it's absolutely true. The disease is much worse than the side effects that we've had. I've actually done vaccination clinics and help work with our mobile teams that are our nurse teams that go out to do vaccinations. So I think it's true. The long hauler syndrome that we were talking about earlier, there are people who have very minor cases of COVID that then come back and have some significant events that occur to them medically that are tied to kind of ongoing symptoms related to COVID. So even if you're not hospitalized, minor illnesses of COVID can potentially seem to contribute in the future to other health problems. There's some data that, as many as 73% of individuals who develop the disease at a month to 2 months after still have some significant side effects in that long hauler type syndrome thing. So the disease does continue to cause damage. It's not just the respiratory system that's impacted, it's the whole body, because the vasculature and everything else seems to be impacted. So the vaccine really seems to have much less side effects as we look at it from a safety profile and clinical trial. So.
All right. Boy, we still have a ton of questions and we have 1 minute left. We're supposed to end right now. I'm going to answer one more question. Or ask one more question, just and then what we'll do, folks, is we'll take these questions, we'll get answers to them, we'll post them in the Daily Dose when we share this video, or maybe after we so that folks will get answers to all these questions and see all the questions that came in, because they're great questions, but I'm trying to skip ones that are somewhat similar to ones you've already answered. Okay. What's a good question? Okay. As we're coming into flu season, is there any recommendation you all have about flu shots? Like if we've gotten the COVID shot, is that completely different than flu shots? Do you still recommend flu shots? And what if there's a COVID booster at that time? Like how do you envision these boosters working? And so there's a lot of questions about the boosters. So how does it work with flu? Is flu totally separate? Do you get a flu shot? Do you get a booster? what if you had J&J, and should you be trying to get one of these boosters in the mRNA piece? They haven't really talked about that in the media.
Yeah.
Those are kind of the
Okay,
booster
I'll do
questions.
speed round on this one. Flu is totally separate. Flu season comes with respiratory season, which is a lot of different respiratory viruses, parainfluenza, RSV, flu, adenovirus, you name it. But the one that has a vaccine is flu, and this will still need a vaccine. We did not have much of a flu season last year because everyone was wearing masks. So that's really the big question, is what's your etiquette going to be during this next respiratory virus season? I am going to be much more liberal mask wearing and hand washing, just because it wiped out the flu. It wiped out a lot of respiratory viruses we see every year last year. So one, Scott Lindquist will get his flu booster. September, October, November, sometime in there. Scott Lindquist will wash his hands. Scott Lindquist will wear his mask, and Scott Lindquist will get a booster for COVID when it is recommended. It is not currently recommended for Scott Lindquists of the world or normal people. If you have underlying immune conditions, as highlighted, the CDC has just authorized, along with ACIP, a third dose recommendation for those with underlying immune conditions. That's usually cancer, you take immune suppression medications. But as far as a booster for the rest of us, that is not yet approved. And it is not allowable under the licensure of the EUA or the agreement that every provider signs that they will use the vaccine. You cannot use that to give someone a booster off label. So there we go. You can probably squeeze in one more question. We could do a lightning round if you got one.
Okay, one more question. Is it possible that a vaccine can trigger an underlying condition if somebody doesn't know they have an underlying condition?
You want to take that one, Kathy?
Sure. I think there's always the possibility, definitely, of a temporal association, right? That it happens at the same time that you get a vaccine. The clinical trials that happen actually look at the broad scope of the symptoms that people have and give information about that. So that usually is, gives us the really big picture of the things that could happen after someone gets vaccinated. And that's the purpose of those clinical trials. Usually there's small things that, really unique individual kind of conditions that get picked up as we move along. But I think that it is possible that if someone had symptoms, it could make them more visible or more aware of those symptoms afterwards. But I'd have to say it would be unusual to some extent that it could exacerbate, unless again they have joint disease already and their joints are sore, which could of course cause more pain or more issues. So those are the kinds of things I would think of that could occur after. Scott, would you concur or add?
No, I totally agree. And just a quick disclaimer, that was my daughter's cat walking across the camera. I am not a cat person. I'm a dog person. So that's my disclaimer.
Okay, one more quick question.
Yeah.
When do we think younger kids will be able to be vaccinated? Do we have any time frame, and how comfortable do you feel with vaccinating younger kids?
Yeah, so it's only our guess. We're assuming it'll probably be later this fall, early winter. I'd be pleasantly surprised if it comes earlier. But this is the time not to rush it. We want a good, careful answer, not a quick answer. And then once I look at the safety data and the efficacy data and the ACIP and all these other regulatory boards look at it, then I'll have a much better sense of how safe and how comfortable I am with giving it. But what I can say today is I'm not comfortable with the rising number of pediatric cases we're seeing with COVID right now in young people. We are starting to see some of the children's hospitals filling up with COVID patients. So that I'm not comfortable with. So I'm not comfortable doing nothing. And depending on the safety and efficacy data, that'll help give my opinion on this. But, just for everyone who's thinking, oh, great, I got to send my kid back to school. What I would say about that is vaccines are not the only way to control this disease. Mask wearing is as effective, if maybe not more in some of these cases. So that at least gives us some structure in the school system, even if you can't be vaccinated. And that is, by the way, why the CDC made the recommendation and the state has made the recommendation for universal masking for kids going back to school.
Great. Oh, go ahead, Kathy.
I was just going to add one piece. As Scott said, that data, the clinical trial information, and then the FDA process, the approval processes that happen for vaccines is really rigorous. Whether it's, even if it's only for emergency use authorization, and then the Advisory Committee on Immunization Practices, which I sometimes skip and just call it ACIP, and I apologize if I use the acronym and didn't explain it. That is a group of really experts around their specific area of expertise. So you have pediatricians and immunologists and all kinds of people that are looking at that data, giving a review of it and looking for, where they're critical, they make the recommendation. So when FDA reviews, ACIP reviews and says, yes, we approve, yes, we recommend. And then again, right now with our third layer with the Western State science advisory work group, that's another layer of experts. And when I look at all of those and I go, those groups all are recommending, then I go, wow, that's just so powerful for me to know that I feel safe. And I feel that that's a good place for us to use as a recommendation. And then, yes, I would trust it if it came through that. So.
That's awesome. Okay, one last question, and this one's a little bit broad. I'm going to paraphrase a couple of the questions I've seen in the chat, and it's the thing I hear the most about, just personally. There's always this question of particularly in the mRNA, is it going in and changing something in me? Is it leaving something in me? Is it fundamentally changing something about me? Those are the questions we get a lot, particularly around that. But let's just maybe broaden it and say for any of the 3 vaccines. Help us understand that.
Yeah, so I'll give you a quick primer on what messenger RNA does. Messenger RNA is just that. It's a message to make usually a protein. And so what this vaccine has, it injects right into your muscle. The muscle uptakes this message to make a protein. And what that protein that your muscle makes, or the cells make, is a capsular antigen. That is what is on the surface of COVID. It's not infectious. It's not a piece of COVID. And the minute it instructs your cells to make that protein, it gets dissolved by your tissues. So no, it doesn't integrate into your DNA. Number one, it's RNA, so it won't get into your DNA. It only delivers the message. Remember, viruses aren't live things. They just use your cells to make, through their mRNA, complete copies of themselves. What this is just giving the cell an instruction to make a protein that then your immune system recognizes as not human, and it makes antibodies. But that messenger RNA that gets injected into the muscle gets dissolved. And so, no, there's no integration. There's no magnetic material. There's no radio material. There's no anything other chemical that is taken up into your DNA or becomes a permanent part of your body. Your body gets tricked into making antibodies.
That's a perfect answer. I would just say although the way that the Johnson & Johnson or the Janssen vaccine works is a little bit different, again, doesn't change your body's ability. What it does is it helps your body recognize the virus, that, molecule that we've all seen on top of everything for the last 1.5 years. It lets your body recognize that and go, I should react to that when I see it. And then it gives you the ability internally to be able to create and trigger your immune system to respond. So it helps your body do that work. It sort of lays foundation for that versus the idea of, changing you in some other way. It lets your body most effectively do that work. So.
All right, we will wrap up. I absolutely appreciate every minute you spent with us. I know both of you are extremely busy in the response. Thank you for everything you are doing. Same with the audience. Thanks for being here. We had over 200 people here today. I think this has been really great information. We will get the questions, we'll get them out as well. This is being recorded, so we will share this with DOH, but we'll also offer it out to other agencies who don't have the benefit of having a Dr. Lindquist and a Kathy in their shop to be able to share it. So if you know of folks in other agencies who are interested, please reach out and make sure we can get a copy out to other people. Thank you very, very much. Everybody take care, and we will get this published as soon as we can. Thank you so much. Take care and be safe.